turn this just a little bit. Okay, thanks.
Thank you. Thank you, Dr. D. Before I introduce our next speaker, I'd like to make a few quick announcements for today. There will be gait testing being done in the Frederick room between 10 and 1 p.m. today. There is no special sign-up sheet or anything. You can feel free to stop by the Frederick room. But at 4:30 to 5:30, there will be a power wheelchair demonstration in the Charles room on the 3rd floor. Once again, there's no special sign-up. Feel free to stop by. At 4:30 to 5:30 today. Yes, Dr. Chuck Levy will be doing that. Okay, between 4:30 and 5:30 p.m. today, there will be a power wheelchair demonstration in the Charles room on the 3rd floor of the Hyatt. There is no special sign-up sheet. Dr. Chuck Levy will be there. And finally, there is a wine and cheese poster session. It's, a lot of science posters, but a few clinical posters will be there as well. So please feel free to come by. It's at the Harborside Foyer between 7 and 9 p.m. today. Okay? Okay, gait testings between 10 and 1 p.m. today in the Frederick room. You're welcome, Sandy. Okay, I'd like to introduce Dr. Stephen Wegener. He is the Director of Rehabilitation Psychology in the Department of Physical Medicine and Rehab. Thank you.
Thank you, Chitra. Can you hear me in the back fine? Good. Thanks, Dr. D, for that great setup. As usual, you've made my way easier. When Doug Kerr and Chitra asked me to come speak to the group, he says, do something controversial, He knows me as somewhat of a rabble-rouser. So I put this title up, Self-Management, Who's in Charge? But when I saw the brochure for this conference, this logo really caught my attention. I don't know if it caught anybody else's attention as well, but I think this is a beautiful picture in the sense that it talks about the integration of science, but also how science needs to be translated to actual living, growing, flourishing activities. And what I want to talk about today, to a certain extent, is, in fact, how, in fact, we can help people with chronic conditions take charge themselves and help themselves flourish. Because, as Dr. D points out, it's not just about the science, it's not just about the biology, it's how people compensate and grow and continue to flourish with various kinds of conditions. And so really, I'm really thinking about not who is in charge, but taking charge. And how do we do that, and how do we, who are clinicians, help people who are dealing with various conditions take charge. And so I'm going to run through a few slides here to set up the problem, and then I'll give you a few solutions or a few ideas that I have, or things I've learned from mostly from other people I've worked with different chronic conditions. I'm going to identify some key challenges that we all face, recognize the increasing role of patients in healthcare, describe some important self-management principles and how I think, particularly in TM-related diseases, we have a lot of work to do in this area. Other groups are way ahead of us, and we'll talk about that in a minute. And finally, give you hopefully some concrete strategies to help improve self-management. Once again, you find yourself speaking to the choir, the people that we need to have, the people who are not here, engaging in self-management by learning. But we talk to who we have, and hopefully we can spread the word. The first thing is that the national and personal health care burden associated with chronic diseases is increasing, will continue to increase. Just a piece of data here, I don't know if you can see this or read it from the back or not, but let me suffice it to say that this is data from the NIH showing the combined direct and indirect costs of diseases and conditions in the year 2000 approximately. Number one is heart diseases, right about 180 billion. But the next one down, at about 168 billion, are the disability conditions. People that we're working with who have DeVix, TM, and various kinds of problems. We're the second most expensive group in the whole country. So there's a lot of emphasis now on how do we help reduce these costs and in turn make life more manageable. It's also true that individuals with chronic illnesses and disability are living longer and are increasingly residing in non-institutional settings, which is actually more difficult to do and requires more services. We've moved people out of the hospital, out of nursing homes, but we haven't helped them do that. We've just done it. And economic pressures and changes in healthcare delivery system are placing more and more and more responsibility on the people who have the condition. But the majority of healthcare resources are still directed at acute care, not rehab and not improving independence. We're spending more money up front, but people are living longer and living in their homes, but we're not supporting them in doing that. There's a growing recognition that we need the increased role of persons with illness, but we're not directing resources to them. And so this increased burden is not being offset by assistance to folks. This is something you all know. And the traditional medical care model and the acute care system encourage a focus on what the doctor is going to do. And this, in fact, I think misleads many of us. It misleads many people, particularly when they move from the acute care situation into the rehabilitation phase to the post-rehabilitation phase. And in fact, people with TM and other chronic conditions are doing a lot of work. There's what I call direct illness work, identifying providers, making appointments, getting the medicines, following through on the programs, going to PT, going to OT. There's indirect work, insurance claims, managed care fights, transportation, researching accessibility, advocating, researching treatment options. You have to bring yourself together, reconstitute the self following any kind of chronic condition or trauma. And you need to accommodate to a lot of changes. There's additional everyday life work. What used to take 10 minutes now takes 40 minutes. Used to take a shower in 10 minutes, and how long does it take now? An hour, 40 minutes. This all takes a lot of time, and there's a lot of work here. A lot of work. And as one person told me, this work is unpaid, untrained, and unacknowledged. And we need to change that. That's what we're going to talk about a little bit today. So there's a lot of work to accomplish. Most of this work is invisible. No one knows what's happening in your house between 5:30 in the morning and 8 o'clock in the morning to get someone up ready to go. There's not a team that exists like there is in the rehab hospital. You got to put it together yourself. The environment is not supportive, really. And it's an unlimited commitment. It's not a short-term, it's not a full-time job. The real people doing the work in healthcare are not healthcare workers. The real people doing the work in healthcare are the people with the conditions. I work pretty hard. Dr. D works harder than I work. But we work 60, 70 hours a week. If you have a chronic condition, you are working, as we say at Hopkins, 24/7. It's not Hopkins actually working 24/7. It's the people who are living with the conditions working 24/7. And I don't think a lot of us are getting that. So the picture is pretty bleak, gentlemen. The world climate is changing, the mammals are taking over, and we have a brain about the size of a walnut. Sometimes I think those of us struggling with these things feel like the dinosaurs and we're becoming extinct. But in fact, I think we can persevere, unlike as my nephew says, the Stegosaurus. So what can we do to respond to these healthcare challenges? I think we need to modify our clinical care paradigms. I think we need to think about health in a very different way. And I think we need to expand our models of research. Let me give you a few thoughts about each one of those things. As we said, persons with chronic conditions and their families are taking a more active role in their health care. Clinicians need to recognize who the healthcare workers really are. That we need to acknowledge this work, we need to train the folks, we need to support them in doing this difficult, important work, and we also need to realize that people come to this situation with a lot of strengths and a lot of resiliences, and they continue to have a lot of assets. The problem with some of these meetings sometimes I find is that we spend so much time talking about what is wrong and very little time talking about what is right. That's why one of the conversations we're going to have this evening that I talked Chitra and Doug to putting on the calendar is how people grow in the face of adversity. And we're going to have those who are interested, we're going to have a conversation about that night. Because people, in fact, as Dr. Kaplan talked about yesterday, if you talk to people with all kinds of chronic conditions, they will tell you what the good things that have happened. I'm not saying it's a good thing to have this happen. I'm saying when bad things happen, good things also happen. And I think we don't emphasize that enough when we're working with people. So I want to talk briefly about self-management. And Dr. D was talking about how we have this kind of transition from the team and the professional people having a bigger role as managers in the acute phase, and over time people are transitioned into taking a more active role in their care. I think that is absolutely true theoretically. I don't think we do a very good job preparing people for this job they have. So we need to recognize that individuals must be active self-managers, that people bring strengths and resources to this situation, and that our main job as clinicians is to be a teacher and a consultant to you who is doing the work. We need to recognize that people have different goals, and that helping people enhance their health, enhance their lives, is as important as symptom management. And finally, self-management is a philosophy and a tool that can be applied to a lot of different problems. Self-management is basically saying that I'm in charge of this situation, and I'm responsible for how it's going to work out, if anyone is going to be. There are 4 critical ingredients to being a self-manager. You need to have some basic knowledge of the condition and the healthcare resources. That's what this meeting is all about. The first step in becoming a self-manager. The second thing is having good problem-solving ability or getting that training. Some people are natural problem solvers, and some people scratch their head. And we need to help identify those folks and train them. People need to learn specific skills, whether that's catheterization or assertiveness, being able to say to the doctor, no, that's not right, that's not what I want. If you can't do what I want, I'll need to find another doctor. Or whether that's pain management skills or transfer techniques or whatever, there's a certain bunch of skills you need to learn. And finally, you need to be good at self-monitoring. That is being aware of what kind of progress you're doing, whether that's glucose monitoring or pain management or exercises. Being aware of how, or whether I'm depressed. Yes, I am depressed, I need to get help for this problem. Being able to monitor yourself. These are the 4 cornerstones of self-management. I'm going to skip this slide. Other illnesses and conditions have made tremendous strides in this area. The arthritis community is probably the leader in the world. They have self-management courses in every state in this country. And most states have at least 3 courses. So if you have arthritis, you can go to a course and learn how to manage arthritis. A group of us at Hopkins have worked with the Amputee Coalition of America, and they now have a brand new program called PALS, which is a self-management program for people with amputations. In TM and related conditions, we don't have this yet. We have yet to develop a self-management program to teach people how to deal with these situations. But I think that's something that this group is moving towards. And while rehab can prepare people for self-management, generally because rehab now is so short and there's so many acute care problems to be dealt with, the phrase now is the people who used to be dead are now in the ICU. The people who used to be in the ICU are now in medicine. The people who used to be in medicine are now in rehab. The people who used to be in rehab are out. People are moving very quickly through the continuum, and we don't have time to teach them the skills we need. The TMA Society, the MS Society can provide assistance, support, education, but we need to get better at developing more formal programs. So self-management, I think, is one answer to this healthcare challenges. Another challenge is we need to think, in my mind, about different models of healthcare. That is, adapt models of healthcare that not only focus on pathology, but focus on health enhancement. If you want copies of these slides, my email address will go up at the end. I'll be happy to mail you the slides. I didn't put the slides in the book specifically because I don't want people reading when I'm talking. I'm sort of egotistical that way. But if you want copies of the slides, I will happy to mail them to you, email them to you. So my email address will be at the end, so you can take any notes. Just listen to what we're doing and think together with me. We don't spend enough time stopping, reflecting, and thinking. We spend too much time trying to write things down. So I think when you think about new models of health enhancement, and just a real brief history lesson, as I get older, I get more interested in history. I don't know why that is, but it seems to be the case. If we look at science and how it's developed, following in the 20th century, science has been tremendously successful in dealing with health problems. As Dr. D points out, we've wiped out some diseases. Some of them are beginning to come back because of poor public health problems, but we've wiped out many diseases. The VA, the NIH, these institutions have come to dominate healthcare, and the focus here has been an exciting but almost exclusive focus on how do we cure the problem. Cure, 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 which is an important thing. However, I would argue that in the emphasis on cure, we have also forgotten how to help people live more effectively who are not yet cured. So we end up focusing on deficits and problems. I would say that's an important, it's necessary but not sufficient. And the sole focus on pathology causes us health providers and researchers to miss variables that may help people grow effectively. And it emphasizes kind of a victim status. Here's what's wrong with you. I mean, the worst example of this is, the person with TM in room 22, not Mrs. Jones in room 22. You talk about the disease, not the person. This is, I think, mostly going by the wayside, but we still see some of this. But in fact, if we look at the research, this approach has some limitations to it. If we try to predict who's going to do well with transverse myelitis or MS or these kinds of things, you look at their quality of life scores, you cannot predict this from the severity of their illness. What predicts it is their psychosocial activities, their problem solving, their self-efficacy, their positive affect. This is what predicts how people are doing 10 years out, not the level of their injury. We see this in people seeking alternative health care. Many people are seeking out massage, spiritual focus in their care. People realize that focusing on the pathology is not enough. And as usual, the clinicians are learning from the people with the problem. We're very slow learners, I have to add. We're very slow learners, but eventually we begin to learn. NIH now has a whole center on complementary alternative medicine, not because the scientists wanted it. The scientists argued against it. It happened because the people went to the senators and said, we want this. And the senators went to the NIH and said, we want an institute. If you don't put an institute in, you won't get your budget this year. And miraculously, the institute appeared. That's how it went down. It was not the scientists advocating, not that there weren't some scientists advocating, but it wasn't the leading scientists who advocated for the institute. It was the people who advocated for the institute. So in a pathologist-focused model, we focus on the germ, the pathology. We focus on treating the deficits. We're working on getting back to baseline functioning, and we have a sort of passive victim person. If you look at health assessment, we're thinking about what's this person's potential? Do we identify their strengths? Can we build those strengths? Can we enhance their function and the person becomes an active manager? It's not one versus the other. It's that we need to meld these together in a more effective way. So, Mike says this very well. Treatment is not just fixing what is broken, it's nurturing what is best. And he says this beautifully in a beautiful writings that he does. So, how can we translate some of these theories into practice? The first thing in becoming a self-manager is to recognize the fact that you're basically responsible. If people who have the condition are responsible, it comes down to that. Because as one person told me one time, well, you go home at night and I go home with this illness, which was a very wise thing to say and helped me realize who's doing the work here. But essentially, while a number of us can be consultants, the real responsible person of people and their families with these conditions. So that means you need to get educated and trained. I mean, some of us have spent, 6, 7, 8, 10 or more years learning about how to do my job. Well, you all are here learning how to do the job, and that's desirable. We need to spread the word on this and help more people do this. It's very important to set short-term and long-term goals. In these kinds of chronic conditions, people need to have some short-term goals they can work towards and some long-term goals so that there's enough reinforcement in the short term to move towards the long terms. Next, you need to realize everyone comes to this situation with strengths and abilities and resources. And the more you can become aware of what your strengths, your abilities, and your resources are, the more clinicians can become aware of the strengths, abilities, and resources of the people they're working with, the more effective they're going to be, the more successful they're going to be, and the more they're going to recognize this whole person that is in the room with them. You need to develop a support system to help keep you going. That's what the TMA Association is about, the MS Society. These people are about this. And Sam was talking yesterday about having a support group to keep you going in the right direction. This is fairly critical. You need to advocate for yourself and for others. That's true in terms of advocating with your personal physician or clinician. It's also true in terms of advocating in terms of the research budget in this country, the ADA, and things like this. This is a job that we all have to take on. And finally, if you look at people who are good self-managers, those people have a purpose. They have some, as the French say, and I say very poorly, a raison d'être, a reason to be. What is it you are doing? On a very practical level, good self-managers prepare for healthcare visits. They realize, like Dr. D's time with her accountant, it's a very valuable but short-lived consultation. So you need to prepare for that consultation. Know what you want. Get your test ahead of time so when you get there, you can talk about the test. How many times have you gone to somebody and say, well, go get this test and we'll talk to you. Well, get the test ahead of time. Call up and say, what test do we need to have? Get your blood work done. So when you show up at the physician's office, the blood work is there. You're ready to rock and roll. You don't want to come and then leave without having action. It's too valuable of a time. Focus on the key issues. If you have questions, write them down. If you need refills, have a list of those things so you can take, if you will, the paperwork off the table very quickly and get to the matter at hand. You need to develop a team of people that you can work with so that you have your own team that's going to help you deal with the work you have to do. You need a system for your records. You are running a business. You have people who you are paying to work for you. If you don't have good people, fire them, get other people. You're running a business here. I mean, Christopher Reeves is somebody brought up the question about Christopher Reeves. If I happen to know Chris, I've been to his situation, he runs it like a business. He has 5 or 6 people he works for him. He comes in, they payroll. He has an office to run his health care. He treats it like a business. Successful. Your business may not be as big as his. You may have the same resources he has. You may be running a mom and pop operation, not GM, but you still are running a business. And you need to teach your doctor how to be a healer. Some doctors are natural healers. Some people don't have that gift. They're very technically gifted, but they're not healers. They can learn from you. How do clinicians help develop self-managers? Well, first of all, we need to respect the work done by people with chronic conditions and give them credit for that and acknowledge that they are full team members with us, and in fact, once we move to the outpatient setting, they are leading the team by and large. We need to recognize they have strengths and resources, and we need to structure a relationship that is collaborative. That is, we're working together on this particular issue or problem. We need to focus on what the patient's families and goals are, not what our goals are. What is it you want to accomplish? We had a very interesting story of a young woman from the Middle East, Hopkins tends to attract people from all over the world, and she was actually a princess. I mean, she was a princess. And so the OTs are working with her in the hospital, and they're saying, well, you need to feed yourself. And she wouldn't feed herself. She didn't want to do the feeding training. And so finally I got in there and through a translator, because my Farsi is not very good. And what she said to me is, that's what servants are for. I want to spend all my time learning how to write my name and sit up properly in public so I can project, because my job is to project, is to be a princess. Project the image of a princess at various places, sign my name on documents and official publications. I have servants to feed me. I mean, our goals and her goals were like this. Once we got beyond, of course that's very difficult for us as Americans to accept because most of us don't have servants around us to feed us. But in fact, her rehab was about not doing that, but about something else. And it took us about 2 weeks to start to listen to her. And once we did that, everybody was totally happy. And we made progress, and she had a successful rehab, even though by our standards, she was unsuccessful because she couldn't feed herself, even though theoretically she could. But she didn't want to eat in a way that may have soiled her in public, which would have been humiliating to the royal family and humiliating to her role in her society. We need to provide better education and training to people with chronic conditions, and we need to realize this may be one person I'm seeing today, but this is this individual's only life. And as visits get shorter and shorter, we tend to forget the very last thing on this page. That this is this person's only case, not their 300th one. Just a brief thing about children with chronic conditions, that this is another developmental task that the child needs to take on. The child needs to become a self-manager of their illness over the course of their life. And so the parents need to model a proactive approach. As the child grows, they take more and more and more responsibility for their care and for their management of their care. And by the time someone is an adolescent, adolescents should be meeting with the physician independent of the parents, at least some portion of the visit. They should go, they have an opportunity to meet with the physician, ask questions, the parents join them later or before or whatever. But an adolescent should be meeting with a physician or nurse or OT independently of the parents. That's the appropriate thing for that child to be doing. Finally, let me just mention about research, and that is we need to begin to do much more effective about including consumers in research. That is, having consumers tell us what needs to be researched, how we should go about doing that, and what does it mean when we find something. We need to have consumers as part of what we call participatory action models of research, where consumers are fully integrated into the research activity. The research needs not only to focus on what is wrong with people, but what is it that helps people be successful. There are very, very few studies. There are none, as far as I know, in MS, TM, or age-related diseases that study people who are doing well. And why are they doing well? I don't mean doing well in terms of their walking, but doing well in terms of they have high quality of life, they're not depressed, they enjoy themselves. We don't know about those people. How did they get there? We don't know the answer to those questions. And consumers need to advocate funding sources to expand research budgets and agendas. You all have power. And don't be, when you pick up the phone, you call that congressman or that senator, you have power. So, how do we help people flourish? Well, first of all, we need to get them the right tools. We need to get rid of the bugs. We need to take care of the pathology as best we can. We need to make sure they're not being harassed by weeds and other irritating things. But we need to find the healthiest environment we can for them to grow on. We need to identify what is hardy, what helps people grow effectively, and you end up with something like this at the end. This is not my garden, by the way, and it's my sister's garden. I kid you not. These are all pictures from her garden, by the way. She's a professional gardener. There's my email address at the bottom there. If you have any questions, please give me a call. I think I'm about on time, or a little over time. Thank you very much. time for one or two questions. And let me just say that there is, as Chitra mentioned, one of the discussion groups tonight is a discussion group about positive aspects and how do we facilitate that and how do we help people grow as one of the groups. Is that at 5 o'clock, Chitra? From 5 to 6:30. There are other ones going on, but being here, I'm going to plug my own. So that's Dr. Kaplan's problem. He can't get anybody there. Yes? That's a very difficult situation. You ever hear the question? Yeah, okay. It's a very difficult situation, but I think you're placed in an untenable situation of you have to, your doctor, I assume you don't live locally, so you're dealing with somebody in some other part of the country. The first thing I think you need to do is you need to get those people talking together. You need to say, I need you to talk to this person over here. If they don't want to do that, you need to find another doctor. If they won't talk to the other person to get another perspective on your situation, I would find another doctor, quite frankly. So that's the very first thing I would do. The second thing you need to do is that you need to be real clear with, ultimately it's going to be your decision, because ultimately you're the one living with the problem. The doctor goes home to his own problems, right? Or her own problems, as the case may be. You need to be real clear what your decision is going to be, and if you're going to decide to say, well, if you will, make a choice that's not recommended by your managing physician, you need to say to them, I want to try this. Are you willing to work with me to try this? Not do it behind their back, but do it just like you would with your tax consultant. I think I'm going to buy this property. Well, I don't think you should buy it. Well, I'm going to buy it anyway. Okay, how can you best help me buy the property? I mean, that's what you're going to do. So I think people make the mistake of not having what I call an adult conversation where two adults are talking and each person making independent decisions. People end up kind of weaseling out the back door if they disagree with you. That does not lend itself. That's bad for you and bad for the provider. So I would say, first of all, they should talk and see if they can come to some meeting of the minds. If they cannot, you need to make a decision and inform your managing physician. This is what I'm decided to do for the time being, or I'm going to try your way, but if not, I want you to be open to trying this in 6 months. Are you with me on that? But make it clear that it's your decision. But you want them to continue. You're not firing them. You're just trying, are they willing to work with you? And get a yes or a no. Other questions or comments? Yes? Well, this is what this is why I preach rather than do, you know. Preaching is easy. Doing is very hard. I think it has to do, just off the cuff on this, is I think you make it clear to your doctor that you're looking for them more than just writing prescriptions, that you want to partner with them and be a partner with them in working on these healthcare problems. So you reframe it right up front that way, and you say it to them. People don't talk to people this way. You know, you say to them, I'm looking for someone who's going to help me flourish as best I can with the condition I have. So I'm concerned about all aspects of this, and I want you to be thinking about that too. Not just what's wrong with me, but how can I do better? So you set what the goal is, first of all. Second of all, when you come to them, you need to bring those other concerns to you. Well, okay, great, you give me this medicine for my pain, but what do you think I can do to help me get out of the house more or improve my function this way? So that you're asking them questions about the things, other aspects of your health and life. So they see that as something you're interested in. And finally, you need to be realistic in the fact that some people don't have that kind of bedside manner, and they're so technically expert, it's worth going to them, and you add someone else to your team, a counselor, a minister, a neighbor, a peer support, who can, if you will, add to the healing power of your team. Some people just don't have that skill, but they're worth it technically. You know, quite frankly, my surgeon's bedside manner doesn't make a heck of a lot of difference to me because mostly I'm asleep when I'm dealing with him. But I want to be very technically, but my primary care physician, I want them to be able to talk with me. Some people you don't care. Just their technical expertise is enough. So let me stop in the interest of time, and I'll be here the whole day if people want to talk. Thank you.